Should we start the webinar, ma'am? You're ready with the presentation. You want to do the trial?
Good afternoon, everybody. And thank you, Dr. Sudhir, for organizing this recording. Okay, fine.
Yeah.
Okay, fine. Yeah, it's recording. So this is the practice where I do my day-to-day dentistry. And this is little my wall of fame, as I would like to say, certain certificates which I have collected throughout the year. And so today's webinar objectives is understanding the science behind the teeth discoloration, because essentially whitening deals with the discoloration. So what is the science behind the teeth discoloration? Plus, we will be differentiating between various teeth whitening methods available to us. We'll identify briefly the indication, contraindication, and the potential side effects. And we'll also evaluate certain case studies, which will be more of a clinical orientation. Right. So we are in a dentistry phase where it's all about aesthetic dentistry. You talk about any field of the dentistry, it has got to do everything with the aesthetic dentistry, right? And it's a branch which is nothing, just compilation of all various branches. Why is that come into existence? Because of the smile revolution. Again, smile is a very global phenomena, and everybody smiles in the same language. You take a Caucasian, you take a African, you take a Indian, where it doesn't depend on ethnicity or the nationality, right? So smile is an official non-verbal language of the world, and it's a global trend. We are focusing on improvement of smile, and which is the whole genesis of the aesthetic dentistry. Why it is important? It is important because we are living now in a world of social media, right? Initially, if you remember, there were hardly any photography available, and if I remember correctly, while I was growing up, we were having those films, Kodak films, in which I think 32 or 36 you could take the photographs in one roll. So the option of taking photographs were limited, right? But nowadays, because of the advent of mobile photography and everybody has a camera with no, what do you say, upper limit of the number of the images you can take, it primarily depends on the storage capacity. So instead of taking a 36 photograph in one roll, where you are very selective about the photographs, I believe if we are going for a coffee or a dinner or a wherever social gathering, you take those many selfies amongst your friends. 36 is nothing, it's not a huge number. So because we are self-documenting ourselves a lot, and not only self-documenting, rather we are posting these pics on social media, which is available throughout the world. Your friend is sitting in US, your friend is sitting in Australia, Singapore, it doesn't matter. They'll get to see your smile, your facial features, your hair, everything. So that's why, and being a dentist, our area of concern is teeth primarily. So there are a lot of things which we can change about teeth. Smile designing is the branch we deal with that. But today, essentially, the topic is whitening. So we'll focus on whitening. That what is the scope of whitening? Is there a demand of whitening? Right. So definitely demand of whitening is there in my professional experience, because patient will definitely come and say कि दांत का कलर ठीक नहीं है, डिस्कलरेशन हो रहा है, थोड़े पीले पड़ रहे हैं दांत, इसका कुछ करा जा सकता है, राइट? There are a lot of reasons of those discoloration and lot of treatment modalities to deal with that discoloration, and whitening being essentially one of the treatment modality, that how to deal with the discoloration, right? So you need to open up. You have to be perceptive about the idea that how can you inculcate this particular mode of treatment in your practice. During my workshops and everything, I noticed a lot of even experienced practitioner will come and tell that rebound ho jata hai, stable nahi rehta hai result, right? So we need to adapt our practice, because if you remember correctly, those who are Those who are relatively young, they don't know, but those who have been practicing dentistry from past 20, 25, 30 years, initially, even in my college days as a BDS, I was taught to do amalgam only. Composite I did perhaps in, I think, internship, not before that, right? So before that, we were doing typical class 2, class 1 amalgams only, and for class 5 GIC perhaps, if I remember correctly. But nowadays, you can't think of doing anything besides composite. For everything, there is variety of composite. There are various composition of composite. It is flowable also, it is fiber reinforced also, it is packable also, it is heated composites also. So we have adapted. Like personally, you have shifted from amalgam to composite. Similarly, whitening is the similar thing, which you can adapt, you can learn how to use it in your practice, and it's a very highly revenue generating procedure, honestly. And it's technique sensitive, but it's not a rocket science. Once you know what to do, you'll be able to generate revenue, right? Like anything, right? A bleaching syringe might cost you somewhere around 2 to 3,000 depending on the brand you are choosing, but patient you can easily charge 10,000, 12,000, 15,000 depending which city, which locality you are practicing. So today my focus is to educate you about whitening procedure so that you can increase your revenue also, and you can introduce a new treatment modality in your practice if you are not doing it so far. So we have to understand the tooth discoloration because we are essentially talking about the color of the tooth. So it has to be discolored. So we need to know what kind of discoloration exists, right? Then only we'll be able to whiten it, right? So there are these two type of primary stain, intrinsic stain versus extrinsic stains. This is, we all have read in our BDS time also, in the bleaching chapter of that endo book, Grossman, hardly 3-4 pages or 5-6 pages of it, but certainly it's more than that. It's really more than that. So, and there are some common causes of discoloration, and you have to basically do the case selection based on from common to uncommon only, कि सबसे ज्यादा क्या रीजन है डिस्कलरेशन को और सबसे कम क्या रीजन है, and what is the treatment modality available to the most common cause of discoloration to the least common cause of discoloration. So here come the diagnostic importance. Till the time you are not able to understand the discoloration type, you will not be able to devise a treatment protocol for it, right? So diagnosis is the first step before you even suggest. So it starts with the consultation before even the patient sits in the chair. You explore the chief complaint of the patient. Now, patient can come in two ways. Either he can come with a said need, what we say, that he's aware and he's asking for teeth whitening, which most of the younger generation are, I believe. The age group from perhaps 25 to 40 is pretty much available, aware of teeth whitening, that there is something known as teeth whitening. We can whiten the teeth and we can brighten the smile, right? So then the category goes into said need. Patient is aware and patient is asking. Then there is second category, which is known as unsaid need. Patient is not aware, but there is requirement. These are the cases which you can pitch for going for the whitening, but not to start with. First, address the chief complaint, gain the patient's confidence, and then once you have a rapport established with the patient, then only you should be able to pitch the whitening. If there is an unsaid need, said need is a straightforward case. आपको कुछ नहीं करना है because patient has come for teeth whitening only. Now your role in that case is just to evaluate whether the patient fits in for the whitening need or does it require something else, right? For unsaid need, you first have to address the chief complaint of the patient and then eventually shift on to the whitening thing, suggesting that it will help. Not, you can't just pitch in, you can't just force, because as a dentist, anyhow we are very ill famed ki, dentists are just there to make money and extract every perhaps single penny out of ourselves. Yes, so that's the thing. And this is the cross section of the tooth. Here, if you can focus, this is the outer layer of the enamel. And if you see the magnified version of this is biofilm and these are stain molecule. So essentially the stain molecule are trapped beneath the biofilm or in conjunction with the biofilm, because biofilm is a something ongoing process in our teeth. It certainly get eliminated once you brush, but if you're not brushing properly or not addressing to the every area, the biofilm layer, maybe of few microns only, tend to stay back onto the surface, which being inherently porous out of the nature will attract stain molecule. Now, the origin of these stain molecule could be of variety of the sources, right? But essentially, it will be onto the outer layer, perhaps in conjunction with the existing biofilm, which patient is inept to clean, or perhaps it has stayed for a longer duration, which we see in a lot of medically compromised patient also, prolonged hospitalization cases also. If some patient has underwent some kind of surgery or something and in ICU, he has stayed for more than 2 weeks or 1 week, the dental cleaning is not that great. So then there is a high chance that there will be some staining. So all in all, extrinsic has to be onto the outer layer. And in contrast, intrinsic stain has to be onto the inner layer. Now, tooth has got two layers, enamel and dentine. Something onto the enamel or perhaps beneath subsurface of enamel is essentially extrinsic. Something deep inside the enamel, deep inside the dentine or in relation with the pulp has to be essentially extrinsic stains. So the stains in scientific language is known as chromophores. And since dentinal tubule is extremely porous tube-like structures, the stains tend to stay there. Now the origin of this stain versus extrinsic stain are entirely different. And our diagnostic ability come in terms of identifying the sources of these stains and the possible positioning of these stains. Then only you will be able to evaluate, number one, whether he is the right candidate for whitening. Number two, if yes, then what kind of whitening protocol or what kind of whitening technique to be used. Because everything cannot be used in everywhere, and there are a lot of treatment protocols which are available in terms of whitening, right? So this is a summary, not the full summary, but yes, to certain extent, in which you have extrinsic discoloration and intrinsic discoloration. Extrinsic discoloration could be because of direct staining, could be because of indirect staining. Direct staining as in the stain stays onto the surface of the tooth, right? And it is not reacting to anything. So it's the direct staining inherent because the liquid you are ingesting, the food you are taking, or whatever habits you have the potential to cause certain amount of discoloration. In this direct staining process, the rule of thumb is anything which stains your cloth can stain your teeth. Not of that intensity, but usual. So tannic acid, it's a very common thing of we ingest tea and coffee. It causes the brownish discoloration. This column is primarily the color it potentially might impart. So tannic acid, again, if you are taking black coffee, if you are taking black tea, strong coffee, strong tea, then certainly, because water is uh, low molecular weight, it is able to penetrate better. So it will cause more. In contrast, if you're taking with the milk, then perhaps it won't be affecting that much. So depending on the intensity, frequency of those substances or the liquid, your teeth will discolor with the passage of time, not with one drink, not with perhaps 50 or 100 drink, but over the period of time. Smoking, because the smoke is there, it may causes dark brown and black stains. These are extrinsic stains. But for the smoking, the first line of treatment is prophylaxis rather than whitening. So the order of treatment is also very important. Chromogenic bacteria, if there is any infection, maybe of throat, maybe of intraoral cavity, maybe of gut, it might, certain bacteria might stay there and will cause various amount of discoloration. And this is only in the terms of lack of oral hygiene, because essentially saliva is a self-cleansing mechanism. And if you're not brushing, then you are letting it mature. So typically green, orange, most common in immunocompromised patient, most common in children, most common in prolonged hospitalization cases. And then there are indirect staining because of the environment you are providing your teeth. So antiseptic causing brown discoloration. Anybody can tell me what antiseptic they think of, if they can respond on chat. What is the
Betadine.
most
Betadine.
common cause? And Dr. Sudhir, can you please tell me the answers if you're there?
Then betadine.
Betadine, Mr. Dr. Abhishek Gule. Okay. Anybody else? No. So most common cause of antiseptic discoloration is chlorhexidine 0.2%. Prolonged used. Patient is coming for regular prophylaxis. Every 6 months, religiously, he or she is coming for prophylaxis, but still she is noticing that brownish stain. So what happens? Chlorhexidine is uh, typically prescribed for 2 to 6 weeks, not for forever, right? So if you patient is using it for more than 6 weeks, it tend to react with the salivary protein and will form a brownish discoloration along the cervical margins. So that is an iatrogenic discoloration, right? The whole focus of informing you this is that if you are prescribing chlorhexidine to your post-surgical patient, to your post-oral prophylaxis patient, always ask them 2 to 6 weeks, max to max. After 6 weeks, max to max, ask for a review and stop and shift them to a routine minus chlorhexidine mouthwash. Then there are some metal worker, those who are exposed to the heavy metal industry like copper, nickel, iron, manganese, silver. These will cause these kind of discoloration: green, blue, black. Mercury and lead poisoning, it will cause typically gray. Then there are certain antibiotics also which causes discoloration, right? Linezolide is there which causes brown discoloration. Ciplox is there which causes green discoloration. Glibenclamide causes brown discoloration. So these are the sources. This is not an exhaustive list, but perhaps the most uh, commonly encountered reason of the extrinsic discoloration, right? So now let's come to intrinsic discoloration. Intrinsic discoloration essentially means that the inner layer of the tooth is getting affected, be it inner layer of enamel, inner layer of dentine, or pulp. So for the tooth structure to be compromised, it has to be some developmental disorder. Like the tooth is too much porous, or too much of hypocalcification is there, or too much of fluoride is there in the water they are ingesting, right? So these are essentially systemic reasons or the developmental reason. So this all points should be clear in your head when you're examining the patient, that what kind of discoloration is there and what could be the probable reason. If you see a fluorosis case, you ask about the fluoride history. You ask about the area where they have stayed. You asked about the antibiotic history, that whatever they have taken. Tetracycline stain is very common, right? So alkaptonuria is a essentially blood disorder which causes brown discoloration because pulp disintegrate. The hemoglobin disintegrate and will result in brownish discoloration, right? Congenital hyperbilirubinemia, this causes yellow and green. And amelogenesis imperfecta, dentinogenesis imperfecta, these are the essentially developmental disorder I'm talking about. Nothing has changed in the cavity, but the structure. If the material is porous, supposingly you have a stone and you have a foam, foam will absorb more of the stain rather than stone or metal surface, right? So similarly, if there is any developmental disorder of the enamel or dentine, which are essentially the hard structures of our teeth compartment, then it become more porous or it become more soft. And if it become more soft, the ingress of the stains become easier, right? So whatever you are ingesting, even if you're ingesting at a low intensity or frequency, it will cause the discoloration because of the softness of the integrity. It's more porous, it's more soft, right? And then there is porphyria. It is also a blood disorder. Fluorosis is very common. We see a lot of fluorosis stain. There is a lot of gradation: grade 1, grade 2, grade 3, grade 4. There are white discoloration, there are brown discoloration, there is yellowish discoloration. So depending on the grade of the fluorosis stains, You need to identify whether it is fluorosis only or tetracycline or whatever, and then accordingly devise that what has to be done. And one of the main reason is aging also. As you age, what happens? That your enamel get wears off, which is known as tooth wear, because you're always grinding your teeth, you're eating, you're speaking. And bruxism is also very common, although we tend to ignore this thing that we are not bruxer. But honestly, I'm also a bruxer. I grind my night guard every 2 year, right? It get perforated every 2 year. It has to be changed, my night guard. So if the patient is grinding the enamel, you have seen a lot of middle-aged patient, 35 to 50 year of patient or 40 to 50 year of patient, in which enamel is gone. Incisal edge, occlusal surface, which causes, because the dentine is typically yellow. The teeth appear white because of the thickness of the enamel. And as aging, enamel thins down and dentines get accumulated. The tertiary dentine, secondary dentine, any noxious stimuli, because, and it is more chromatic, the dentine which get accumulated with aging. So two things is happening essentially. One, enamel layer is going down, dentine is becoming more chromatic. So that's why if you notice that the chroma is highest in the cervical region. Why it is highest in the cervical region? Because enamel is thinnest in the cervical region. So imagine this thinness progresses all over the incisal edge. Teeth tend to become yellow. And then there is plethora of reasons of losing enamel, which is tooth wear, right? Tooth wear, erosion, abrasion, attrition, right? Your habit, your lifestyle, this all turns down the enamel. So in this cases, is bleaching the right option? If yes, what is the protocol? So all these things can be addressed with bleaching to an extent, but in what way, which capacity, that you need to identify, right? So this is the diagnostic importance in understanding the discoloration of the tooth. So these are some clinical picture. If you see this picture, what do you see? Is this a good case for teeth whitening? You can write on chat also, or you can unmute yourself and respond also. Let's make it little interactive, because honestly, speaking in front of a camera, it's very boring. So anybody?
Yes.
Yes. Okay, Dr. Smita has said yes. You guys agree? You guys don't agree? Right. So there is a need for whitening, but first the need is of this blackish shadow. Although the image is not very clear, I'm sorry, I was trying to find a good image, but this was a very apt image in terms, because of the yellowishness, the focus on this blackish area is not there. So first of all, we need to remove this decay, then do the cleaning, because this is more of a biofilm, right? After oral prophylaxis, we will evaluate the need for the teeth whitening, right? So this is the approach to a case, and this is just entirely clinical approach. Here I'm not trying to identify reasoning for the discoloration yet, because once the surface is clean, decay is gone, then only will I evaluate the need for the whitening, right? Now this case, is this a good case for whitening, or can we straight away go for whitening? That is also a very important question. Right. So in this case, if you see, there are a lot of composite filling, right? Like class 4 fillings are there, perhaps because of, and you can see that there are a lot of crack lines available, right? This is there in central incisor. Even in mandibular incisors, you can see there are a lot of craze line, fracture line available. Perhaps because patient is bruxer, perhaps because patient has a habit of pan chewing, betel nut chewing, whatever, right? Or excessive gymming also. Gymming also causes this kind of thing. If the patient is not wearing sports guard, right? So these are a lot of vertical crack lines, right? So we need to address this thing, that what is the approach for this composite, for this discoloration, plus this cervical exposure of the sorry, this root exposure also. If you see in canine, in central incisor, in this central incisor, in this lateral, in this canine, it is a lot of attrition, abrasion, right? This is also, this, the incisal edge flattening is because of attrition. So this is a multidisciplinary approach case. Whitening could be one modality of the treatment, essentially. But After what? After which step? This is again another case in which patient came straightforward कि दांत का कलर मेरे को ठीक नहीं लग रहा है. But is this a case for whitening? In my opinion, this is the case for oral prophylaxis. And we did exactly that. And you ask the patient after doing the prophylaxis if he or she is happy with the shade or not. And people are happy, and some people are not happy. Those are the cases which you go for whitening. Right? This will typically complain with जो हम लोगों ने हमेशा oral medicine की sheet में लिखा होता है ना, dirty teeth. This is typical case of dirty teeth. Because patient has the habit of pan masala chewing, tobacco chewing, smoking. So these all stains are there, right? So the first line of treatment modality is not whitening here. First line of treatment modality is oral prophylaxis. There is an order of protocol, right? In this case, this is little extreme, but patient did come about this discoloration of the tooth. Patient is not bothered ki there is no tooth, right? Patient is bothered, it is discolored. I don't like the blackish tooth. So in this cases, you won't go for bleaching. In this cases, you will go for root canal perhaps, or composite filling, depending on the pulp exposure, right? So identify the case, identify the treatment protocol order, that what has to be done first, right? If this is the case, this is a perfect case for teeth whitening because patient has yellowish discoloration in this. Canine are naturally darker, so we don't focus too much on canine because canine is usually one shade darker than rest of your natural teeth. Then there is some cervical stains over here also, right? This is looks like essentially a case of trauma in which perhaps there is a lot of secondary dentin deposition, and we can deal with this with teeth whitening also, right? But will you whiten the whole teeth or will you whiten only these two teeth? That is the question as a clinician you should be reflecting on. कि सिर्फ सेंट्रल इंसाइजर पे व्हाइटनिंग करनी है कि फुल आर्च व्हाइटनिंग करनी है, अपर लोअर दोनों करनी है कि खाली एक ही करनी है, राइट? So there comes the clinical experiences and the understanding of the mechanism, that what will happen if you opt for single tooth bleaching, or in this case two tooth bleaching, versus single arch versus full arch, right? So far clear? I think little. So what all materials we require? There are two material essentially. One is hydrogen peroxide, one is carbamide peroxide. We use for teeth whitening. Hydrogen peroxide, carbamide peroxide is nothing but addition of urea in hydrogen peroxide. If hydrogen peroxide is mixed with urea, it becomes carbamide peroxide. And this is the equation you need to remember, that 10% of CP is carbamide peroxide, HP is hydrogen peroxide. 10% CP will yield 3 to 4% of HP, because eventually CP will get dissociated and HP is the only molecule which causes the whitening of the teeth. CP will not cause. CP will get transformed into HP, and then HP will disintegrate and will cause the whitening. So essentially the whitening moiety is HP, right? But what is the need, that why do we need to add urea in HP and create another molecule, carbamide peroxide? Because HP is highly unstable. It declines rapidly. The moment you put, hardly 30 to 60 minutes, right? And after that, it is as good as a plain water, because all the efficacy, all the nascent oxygen is released at once, right? So do you want it to be released at once, or do you want the slow release of these oxygen moiety? So carbamide peroxide is relatively stable, and stability comes because of the addition of urea. Urea make CP stable, and the decline rate is 2 to 4 hours. So if you want T20, you have to go for HP. If you want test cricket match, you have to go for CP. That's the basic thing, right? So you need to identify किस केस में क्या लगेगा, क्या जरूरत है. And one more thing which has happened because of addition of urea is pH. pH rises to 8. If the pH rises to 8, then what will it do essentially? It will make it alkaline. If it will make it alkaline, it will prevent or inhibit caries also. Because acidic will promote caries. So after bleaching, if you leave the teeth in an acidic environment, it is more prone to decay. It is more porous for potential decay. So pH 8 is very safe for us, right? And it will not cause sensitivity also. So what is the science behind all this whitening agent? What is the chemistry of the whitening agent, which we briefly talk about, this HP and CP? How whitening work? What is the role of pH? What is the role of concentration? Because bleaching gel comes in various concentration also, right? Various pH is something we have worked upon as the material size is advanced, and exposure time. So essentially, as a clinician, we need to focus on the concentration and the exposure time, that what concentration is required, what exposure time is required according to the clinical case, right? So the mechanism, the exact mechanism is not understood according to the literature, but it can be activated by chemical activation, by heat or light activation, or could be dual. Why do we need to activate? Because the supplier can't supply you in an activated mode. If they supply you in an activated mode, the shelf life he cannot guarantee, because the moment it is packaged at an factory compound and the moment it is delivered to you, there could be as much gap as 6 to 8 months, 1 year, 1.5 years. So for the sake of logistic and transport, it has to be supplied in a stable form, which has to be activated when it is required, not before that, because you want to have full efficacy of the agent you are going to use, right? If it is pre-activated, then the efficacy certainly will be compromised. So activation, these are the activation modality. Chemical as in two component, typically just say anything which we do in dentistry, be it our cements, be it our alginate, be it our rubber based impression material, be it our luting agents, it is essentially supplied in two components. And the thing is this, it is supplied in two component because it has to be in a flowable consistency when we use, and it has to be set after the working time has elapsed. But in this situation, it has to be activated so that the ingredient is active when we are applying onto the tooth structure to achieve the desired result. So chemical activation, as in two tubes you are provided, which you mix, and then the activation occurs. Once the molecules are mixed, the chemical reaction happens, just like composite. That composite is in a plastic stage before light curing it, and once you expose it to the light cure, it sets. The similar thing happens in the chemical activation, that once you mix two chemicals, the reaction starts, the propagation starts, and a lot of oxygen is released, nascent oxygen is released. So that's the chemical. But if you are using light to induce this reaction, heat or light, initially, like in earlier days, light were used. Nowadays, practically even heat, light is also not used, unless and until you're resorting to certain bleaching gels which require light activation, or it could be dual. You can hasten the process because you are chemically mixed also. Any reaction will be accelerated once it is exposed to heat or light. So if you want to achieve a higher result, or intensity of the result to be more prominent, then you can use heat and light. But the major drawback is that we are using it on a vital tooth structure, right? I'm not talking about non-vital bleaching here. I'm talking about only vital teeth bleaching. So vital tooth bleaching, there is pulp there, right? And if you are using too much of light, the pulpal temperature raises. Similarly, like light cure also, when you are closer to the dentine complex, like RDT, remaining dentine thickness, if it is less than 2 millimeter, then ideally you should cure it for longer, right? Your light cure should be of low intensity, but for 20 seconds, 30 seconds, right? So that it takes the time. But if you are closer to, and all this 1 second curing light available, and if you cure the your liner or your flowable base or your first brace with 1 second light cure machine, the intensity is too much. What happens? The pulp becomes sensitive because of the stimuli it gets. So similarly, although we are applying onto the tooth surface, But if you are inducing the heat or light, it has the capacity, and it is documented in literature, the pulpal temperature can rise as high as 5 degree. And 5 degree is good enough to cause irreversible kind of sensitivity. So because of the data, because of the evidence, mostly this light induced, like people who have been practicing dentistry for some time, in I think in 2010 to 15, there was a huge rage about this Philips Zoom whitening light, right? But eventually it is withdrawn from the market, or it's not so much used now because of the potential side effects it was causing. Because of the light, it is raising the pulp temperature, it is causing the sensitivity, right? And you can use dual also, but dual, if you're using, use low intensity light, not high intensity. And what essentially happened, that the free radical generation happens, right? So again, this light activation, which I was talking to you about, that some manufacturer advocate. So whenever you are buying any bleaching product from the trade fair, from the vendor, local vendor, or even online, there comes a MSDS sheet with the data, right? Material safety data sheet. Read it. It's very low in font, but read it so that you get to know what the manufacturer is recommending, then how to use it, right? And the light activation can be done from the halogen light also, LEDs also, lasers also, right? Laser tooth whitening is also a concept. But the hydrogen peroxide in high concentration is not required to be light activated, but in low, it might be helpful, right? So you need to understand what concentration HP the manufacturer is providing you with. If it requires light activation or if it doesn't require. But essentially, high HP doesn't require. So this is the process. This is your hydrogen peroxide. It, because enamel is also a porous structure, so it basically diffuses once you apply a layer on this. It is a gel-like layer, just like your etchant, the bleaching agent. You apply it in certain thickness and let it sit on this external surface for a while. It could be 10 minute, 15 minute, 18 minute, 20 minute, 30 minute, depending on the manufacturer, depending on the substrate you are dealing with, right? So gradually it penetrates, and the nascent oxygen which is released, it dissociates into water and nascent oxygen, right? This nascent oxygen penetrates onto the tooth structure and will cause the molecule, the stain molecules, to break down and will result in whitening, right? So if you see, this is the pigment, or this is the pigment, it's a broader particle, right? A large particle. But supposedly, if you have a hand with finger joint and finger splayed, the kind of light passes with the finger splayed, जब आपकी उंगलियां खुली हुई होती हैं, the amount of light passes through that open fingered will always be more than your closed finger or the palm, right? So this is essentially the concept, because the pigment is not going to go anywhere, it is going to stay there, but it is going to go get break down into smaller particle. So once this pigment break down to these smaller particle, the amount of the light passing through these molecule will be much higher than this. It's like a blackout curtain, it's like a sheer curtain, right? So the light will be more passed out through the sheer curtain, and the more light it allows to pass, the more whiter it appears. That's the basic concept of teeth whitening, that the oxygen free radical disintegrates this pigment into smaller size, right? Which allows more light to pass through. So this is basically the bleaching agent get reduced and the tooth get oxidized. That's the basic reaction which happens in the scientific terminology, right? So what are the, so far we have discussed about the cases, case selection, types of stain. So what are the treatment option available? We have, in as a professional, we have in-office whitening, we have at-home custom trays, which is also known as night guard vital bleaching, and we have over-the-counter products also, not so much popular in India, but yes, people are resorting, a lot of patients are resorting OTC products. And then LED and lasers, what you should know. So let's discuss briefly this about. So these are over-the-counter products. It typically comes into a strips kind of thing, or this kind of light and laser some pen is there, something you paint on. There are a lot of modalities available, but these are the most common. The strips, you place it against the teeth, let it sit for some time, and then you keep it, took it off. But the problem is this: the control of the bleaching agent is not there, right? If the patient is applying the strip here, it might leach onto the gums. If the patient is applying this UV thing, patient is applying the pen, they don't have the control. We are trained, we know how to protect the gum and gingiva, but they are not. They are just using it for whiten the teeth, right? And later on, they come to us with the sensitivity, with the gingival recession also sometimes, right? And then DIY, there are a lot of DIY. There is Pinterest, there is Insta, there is plethora of social media platform in which a lot of influencer, like, this coconut oil, turmeric, baking soda, you just mix it and, whiten it. There is this strawberry and baking soda. This is this lemon and baking soda. So these are DIY, but the problem with OTC and DIY is the extent of the control. Patient doesn't have any control that where will it go, what will it injure, what will it cause. But as a professional, it's our job to educate them. It's something like when previously patient used to come, the only resort they knew was to extract the tooth. Now patient knows RCT is there, re-RCT is there, implant is there, and it has come to existence by public education only. Dentists like us or the student or the institution have educated patients that there are replacement. Despite pulling out tooth, you can save it. So similarly, it's our professional duty to advise against usage of all this thing. All the abrasive and the whitening toothpaste also, I have strong reservation against it, because all of them have some abrasive content. Be it any whitening toothpaste from any leading brand, it has got to have certain abrasive, which results in what? Which results in enamel wear, accelerated enamel wear. And once the enamel wears down, instead of getting a whiter result, the teeth will eventually become yellow, because the modifier, the light enamel is basically the light modifier. If the thickness gets reduced, the teeth will become yellow. It may temporarily appear because of placebo effect or because of the psychological effect, but essentially, if the enamel wears down, the teeth will become yellow. So let's talk about the professional thing, in-office bleaching. So in-office bleaching, there are various brands available. This is Opalescent, this is Polar Office. I think these are the two common. Money has also come. And there are a lot of other brands also which offer in-office bleaching. So there are two type of bleaching. One is in-office bleaching, one is home bleaching, right? Night guard vital bleaching. So these are the product comes into various concentration. Opalescent typically comes in 40%. I'm not very sure about Polar Office and Money. But yes, somewhere around maybe 25 to 40% should be the range available in the India, right? Because the concentration varies according to country also. But here everything sells. Night Guard Vital Bleaching, you have, I don't know whether any other brand sells it or not, but Opalescent has a system which is Ultradent. It's one of the gold standard of industry, and it's a gold standard from past 40 years, right? None of the company is able to beat this, right? This is, again, if you can see the various color, it basically donates 10%, 15%, 20%, and 45%, right? This typically comes in this syringe. This is 1.2 or 1.8 ml syringe, and it lasts for 2 weeks. If you give that patient, and it has to be used in conjunction with this bleaching trays, right? This bleaching tray is with reservoir. There are several designs of bleaching trays which you can formulate, with reservoir, without reservoir, various thicknesses, what kind of adaptation is required. This varies according to the need of the desirable bleaching effect you are looking for onto the patient. And the concentration also, whether you are going to use 10%, whether you are going to use 15%, 20%, 45%, it also varies. But unfortunately, in India, we only have 10% available. But in UK and European country, you have 15, 20, 45 also available. So 10% is the PF I'm prescribing to the patient nowadays, right? And it has to be used with this custom bleaching press. It can also be used with the aligner also, right? Because aligner is also the same template. And for this non-vital bleaching also, Ultradent has got an endodontic whitening system, which comes in the name of Opalescent Endo. right? So I'll show you the cases where these are used, right? So in total, 3 things for professional: in-office bleaching, hydrogen peroxide, this is carbamide peroxide, and this has to be essentially used with bleaching trace. And for endodontic discoloration, tooth, non-vital. Non-vital means it has to be RC treated, right? For that, this is a separate system. So if you talk about the advantages and disadvantages, which I briefly discussed while talking also. So OTC and DIY, it's a big no. I will not recommend, and I will recommend and request all of you to educate patient that there are a lot of harm also. And it necessarily doesn't result in whitening. There is no evidence to suggest. It's all questionable. What is the efficacy? What is the safety? OTC maybe because it has got 3 to 4%, 5% of HP. So if the patient is using it over the period of time, maybe. But then what is the risk benefit ratio? You might damage your gums, gingiva. You might land up into sensitivity. So as a professional, you can ask for them that safer options are available. And in office whitening, supervision is required. Home whitening, supervision is also required, right? The active ingredient here is HP. It could be HP or CP also, home whitening, right? The concentration for in-office whitening is typically up to 40%, and at home, it's 7 to 35%. Like I told you, 10, 15, 20, 45, it's like that, right? Activator could be in office, could be chemical, could be laser, could be LED. But at home, essentially chemical, because patient doesn't have LED at home, patient doesn't have lasers at home, right? So this is in-office bleaching only, right? Efficacy and safety, both of them are good if done properly, if the patient is educated properly, because dentistry is again a stream. It's not like medicine. You have to have a cooperative patient, especially for something if they are doing at home, right? So you have to educate the patient. Either you educate or your assistant educate. But the assistant training is your responsibility. I'm not telling that every patient you have to educate, but dedicate an assistant who is aware what are the pros and cons patient has to be done, when to report back to the office, what are the signs to observe. This all preferably in a printed sheet should be given to the patient if patient is opting for home whitening, right? And ask him to read this while in the waiting or in the operatory and get back to you with any questions if they have, right? And you always, whenever you are starting any patient, you always recall 1 week. Like supposingly you have done patient today, after 1 week, call him for a recall visit to see that everything is going well. There is no gingival blanching, there is nothing, because sometimes patient overload the tray, right? कि ज़्यादा लगा देंगे तो ज़्यादा जल्दी हो जाएगा. But that's not the situation, right? So that's the mentality, that's the education thing we have to emphasize and keep on emphasizing so that it goes and sits into the patient's psyche, right? Again, in-office whitening is little bit expensive than at-home whitening, right? Because you, not essentially because of the cost of the component, because of the clinical time you're investing. Your chair is occupied for good amount of 40-45 minutes maybe, right? So 45-minute clinical time makes the cost expensive. To start with, perhaps you can offer at a low cost if you are not confident, and then gradually build your practice once you're confident, right? Once you have a trained assistant, then your clinical time is not invested, only your chair is get occupied, right? So we can plan on that accordingly. So there are certain clinical protocols which have to be followed, right? With any procedure we do in dentistry, there are certain SOPs to be followed. First is isolation technique. Isolation technique is nothing but saliva, right? So saliva, we can use either suction or we can use cotton roll or, right. But why the saliva isolation is important? Saliva isolation is important because first, saliva is a continuous process, right? Because if the patient is sitting, let's say for 30 minutes also in your chair, 30 minutes mein kuch volume of saliva aega. What will happen that it will wash down the bleaching gel, whatever you have applied. Because anything you apply, any dressing also you applied, perio dressing or maybe sensitivity paste or whatever you apply onto the tooth, eventually it wash down within 10 to 15 minutes, depending on the rate of the saliva production, right? So first of all, if the bleaching gel is getting washed out because isolation is not done properly in terms of saliva, then the efficacy of the bleaching gel will reduce because the concentration come ho gaya. It is washed down by the saliva. And second, what will happen? These bleaching gel are designed to stay on the hard tooth material, right? Not onto the soft. और अगर आपने saliva control नहीं किया है, then what will happen? It will leach onto your gums, it will leach into your vestibule, buccal mucosa, lingual mucosa. It could leach anywhere because saliva is liquid. Bleaching gel is a in gel consistency. Once you have applied, it doesn't move, provided it doesn't get diluted. The moment it get diluted, it will get the flow. And what will happen? It will cause chemical burn for sure. No matter what you use, patient will immediately complain, wahan sensitivity ho rahi hai, right? So that's why isolation is important. And normal regular cotton roll is enough with a cheek retractor. And there come a lot of cheek retractor in which you have lip retractor also, so that the patient has this tendency to put the lip against the lower teeth. And the saliva seeps in between the interdental spaces of mandibular incisors. And typically lower incisor mein you see a lot of chemical injuries because of that. If you're not, if you have not put a cotton roll there, or if you have not used the cheek retractors specifically for bleaching, because they essentially comes with tongue retractor also, and it comes in various sizes. It comes in a lot of local manufacturer also, like and Ultradent also provides it. It comes in silicone also, it comes in plastic also, and it comes in various sizes also. So you can choose according to your patient's mouth size, lip size. There are guides available in which you can choose it. So essentially what it does, it keeps the tongue retracted also. And along with those retractor, you can put cotton rolls also. And intermittently, you can ask the assistant to use the suction. Low wax suction, high wax suction, it doesn't matter. If the saliva pooling is noted, just suck it out, right? So this is your saliva isolation. Then comes the gingival protection. Gingival protection, because you are putting it onto the cervical margin of the tooth, right? And cervical margin is in close contact with the gingiva. And seepage will happen. So liquid dam is the best thing to practical thing to isolate the gingiva. You can use rubber dam also, but rubber dam has to be the seal, the inverted rubber dam seal has to be impeccable. Otherwise, because you can't see, rubber dam are not transparent, they are opaque material, right? If you are using rubber dam, then you have to tell patient to give yourself non-verbal signs, raising the finger or whatever, or whatever, writing on the mobile or something like that, that any burning sensation is there. And this you have to tell the patient while you are using liquid dam also. If there is any sensitivity, patient will be able to point the finger, right? But if you have applied it liberally and generously, it is hardly a problem. Then there are various agents, concentration and duration. Like HP also comes in 20%, 30%, 40%. So it can be used, the 40% can be used for 10 minutes also, can be used in 10 minutes for 3 times, can be used for 30 minutes in 1 time, right? So max to max HP has to be stayed on the tooth 30 to 40 minutes, not more than that. Even in one go, if you're applying it. Ideally, the protocol is to apply for 10 minutes or 15 minutes, wash it off, apply the fresh layer, right? And then there is managing sensitivity. Despite taking all the precaution, if there is sensitivity, what will you do? And that's a very, not very common, but a documented cause of the sensitivity, right? So in this, you can ask the patient, the first defense mechanism is educate the patient before you apply the bleaching gel, right? If any sensitivity, if any irritation, immediately wash the product. Immediately. Even if it has been there only for 30 seconds. If the patient is complaining of sensitivity in any region, you just wash that product, apply the liquid dam, and then reapply the bleaching gel and see if the sensitivity persists. But supposedly there is a delayed sensitivity, then you can put the patient on desensitizing paste, right? To manage the sensitivity. And usually it's a transient sensitivity. Hardly, in my experience, hardly 2 to 3% of the patient experience the sensitivity. right? But you have to be impeccable with your isolation technique, with your gingival protection technique, and application of the bleaching gel also, that it shouldn't go or it shouldn't stay where it is not meant to, right? So misdiagnosis again. If there is blackish discoloration because of the caries, the first slide what I've showed you, if it is because of that, bleaching will not correct it. It has to be managed with a filling only, right? Because decay has to be removed, a filling has to be done, right? And then what was the most common mistake we dentists do? We over promise all the result. आप इम्प्लांट करा लीजिए, लाइफ लॉन्ग है, राइट? आप क्राउन करा लीजिए, 15 साल की वारंटी है. You don't need to over promise, because material, you know, the kind of forces patient is generating, that you don't know. And in bleaching, it is unpredictable. Trust me, once it happened, and she was a radiologist. She came for bleaching, although bleaching was not required that much, but she came for bleaching just for fun. Okay, you know, I want to whiten the teeth. I specifically told her it's not required, it's going on good with your skin color and everything, but she insisted. And to my wonder, there is no shade improvement, zero shade improvement. Imagine. So this has happened to me once. Despite following all the protocols and everything, there was no shade improvement. Hardly maybe 10%, 20% of a shade improvement is not an improvement. It has to be one shade improvement, right? And it was not there. So don't over promise the result. You just say the patient that you show your before after cases. If you have not done and you are doing it for the first time, you drop me a message. I'll share my cases for before and after, and you tell the patient these are the cases done with the bleaching, but the result is highly individual. We can't predict how much bleaching will happen, right? But then in office bleaching, night guard bleaching, we can manipulate, we can do. It's not that teeth can't be bleached, but typically in India we do in office bleaching कि आपने वो आधा घंटा 40 मिनट के लिए लगाया and patient is happy with the shade improvement. But because it has happened to me personally, and for the first time, it was a shock of my life also. So you just show the patient before after, and you tell the patient it is dependent on your tooth structure, that how much bleaching is achievable, right? So don't overpromise the result, always underpromise the result, and be realistic about it. You are not cheating the patient, you are using best of the product. Don't use expired product, don't use pre-mixed product. Hota kya hai ki sometime you mix the syringes, company says that it can be stored into a refrigeration for up to 7 days after activation, and it will be as good as new. But in case you are using those kind of product, then use a fresh product, right? Charge the patient accordingly if that is not working, right? So use good quality product, follow the proper protocol, check whether the product is expired or not. So you take all the due precaution from yourself, but at the same time you inform the patient, right? It is highly subjected to your teeth, your anatomy. So this all comes into patient education, that what to expect, what kind of sensitivity. You have to tell patient there is a chance of 2 to 3% sensitivity post-operative, right? It is manageable, it is transient. 90, even in 2 to 3%, 90% of the time it is transient. And then remaining 10-15% of the cases, it is manageable within a week. And that's like rarest of rare cases. So far, I think out of how many cases I've done, only one patient, right? In which the sensitivity continued for 10 days. But yes, we managed it. It's a desensitizing paste. There are a lot of medicament also available, which you can apply just after the procedure. And poor technique. Poor technique is again, any isolation failure, any soft tissue isolation failure, any expired product, any lack of supervision. If you're doing it in office, you have to be vigilant. You have to, like first 5 cases, choose your assistant who's going to assist you in that case. Train that assistant so that you are mentally free. She or he is trained to look the things, and patient can communicate. You educate the patient also about communication, and most common cause is sensitivity only. Any, you know, irritation or a burning sensation, these are the only complaints patient does about, right? And Indian patients, sometimes they don't even do that. We are very blessed to, I mean, I feel the starking difference when I practice in UK and when I'm practicing here. There, I Simple thing, even the patient will complain. Here, even if accidentally, you have touched the tongue with the burr, patient will not complain. So we have our pros and cons practicing in India. So let's talk about the some before and after cases and the treatment protocol we have used in that. So there are various bleaching applications. Bleaching can be done as a standalone process also, and in combination with various adjunct treatment, right? Because bleaching is essentially aesthetic dentistry, and dentistry is nowadays more of a multidisciplinary approach. It's not a one-man show, right? We need a lot of, being a prosthodontist, I need perio opinion, I need endo opinion, I need oral surgeon's opinion, I need implantologist opinion, right? There are even TMJ specialist opinion, supposingly, right? So you have to have a good collaborative team in which you can do your case discussion, right? So similarly, bleaching is also a process of aesthetic dentistry and can be used in various adjunct treatment. And there is pre-restorative bleaching, which is also one thing, right? So this is simple case. Patient has come, yellowish teeth, nothing significant. We just bleached it and the shade improvement has happened. So this is in-office bleaching. It came with 2M2 shade, one session, and it resulted in 1M1. And patient is happy with this kind of result and we are done with the case. It's a very simple, straightforward process. In this case, patient has got this crown done. I think these were Emax crowns. Yes, these three. Yes, these three are crowns. These four are crown, right? From 1, 2 to 3, 3. Sorry, 2, 3. These are the crowns. You can see here, right? And the patient was not very happy with this yellowish teeth, right? So we did oral prophylaxis and then we did bleaching. So once we did the bleaching, you see that there is slightly mismatch. But since this is an in-office bleaching and the teeth are dehydrated, once it will get rehydrated, the little mismatch of the shade, if you can notice, will get sorted, right? This is just immediate post-op. Had I taken a recall picture after 24 or 48 hours, it should have matched perfectly, right? And this is one case in which this is post-ortho case. Yes. And we did bleaching here. This upper arch was bleached and we did bonding here. This was the decay, proximal decay, and this is the bonding. So the question is, can bonding be done immediately after bleaching? No, you have to wait certain time. You have to stabilize the bleaching result because otherwise your composite will not match. So once you have done bleaching, and do your bleaching before your restorations, right? Once your bleaching is done, shade is stabilized, then you go for restorative filling so that your restoration matches the tooth. Otherwise, if you do immediately, you will end up choosing a restoration which is of high value, right? This is discolored tooth, trauma, fractured, you can see incisal edges. So this is basically done with non-vital bleaching, that opalescent endo I have told you. So after root canal, opalescent endo was placed, and this is just composite bonding, no crown, right? So this is minimally invasive dentistry. Because I have been trained into being a minimally invasive dentist, I don't put crowns after every root canal if it is not required, because there is a SOP about when to provide crown, when to provide post and core, what kind of restoration addition protocol you can use. So accordingly, in this case, it is fair enough to use, composite bonding also. This is again a case, patient is not happy with the shade also, shape also. So on standalone, whitening will not resolve the patient aesthetic need because the shape is not all right. And bleaching is essentially deals with the shade, not the shape. So you bleach this teeth, right? These two teeth. Once patient is happy, you are happy with the teeth color, you wait for some time and then you do the composite bonding, right? This is pre-bleaching, this is post-bleaching. And this is simple. Class 4 composite, we have done, right? This is a fluorosis stain. Patient was having stains in only these two teeth, prominent brown stain. She has come only for this, right? But she never wanted to go for veneer, right? So we opted for bleaching, and it was a combination bleaching. It was in-office bleaching also, it was night guard bleaching also, and we were able to achieve this result, and this is follow-up after a year. So there is shade improvement and patient was happy with this. We could have done something add on to this, which is known as microabrasion, but patient was not willing. So she was happy and we just left it there. This is the brown stain. Like here, it is light brown stain. It could have been dealt with microabrasion. Like here, this is the stain. So if you use microabrasion is nothing but a slurry of a abrasive, right? And it removes the brown stain. You basically polish it off and then the brown stain is gone. So this is bleaching in conjunction with microabrasion. You need not to put composite. You need not to put veneer. I mean, you can be minimally invasive. If the patient is not happy with the result, you can always go for a composite bonding. Because for this composite bonding, you have to remove some tooth structure, some enamel, which is a irreversible removal, right? And if the patient can continue with the natural substrate and clinically acceptable result, I mean, I don't see any need for put a composite or put a veneer on this tooth, because this is clinically stable, patient is natural. Because anything you put onto the tooth, be it a simple filling, it has got a failure cycle or a restorative cycle that eventually, let's say the documented restorative cycle is roughly 10 year, average 10 year. It could be 7 year also, it could be 12 year, 15 year also, depending on how the patient is maintaining it, right? So if you're putting anything restorative here, and especially in this, so you will put it like this, there will be margins. Those margins might end up discoloring over the period of service of the restoration, right? And eventually you'll have to replace it. While replacing, you'll have to dig more composite, more tooth structure around it to make the margins invisible, right? So eventually you end up sacrificing more of the tooth structure, right? But in this case, this is patient's natural tooth structure. It doesn't need any maintenance. So if natural tooth structure is preserved, it doesn't need any maintenance. Any restoration you put, be it simple pit and fissure sealant also, it requires some amount of maintenance. So before doing any restorative work, because bleaching is essentially a very ultra minimally invasive reversible treatment modality, right? This is again bleaching simple. This is single tooth discoloration. We have done single thing. These are the white stains, if you can notice, all right? With bleaching, it become more white. It will not, you can't be selective that this, the whole substrate will become white and this will not become white. Because even if you leave this area, there will be some diffusion, some percolation of that nascent oxygen, which will make it even more whiter. So there is a resin infiltration treatment available with FGM, I think. It's known as Icon, in which you do the resin. See, this is post bleaching, right? And once you do the resin infiltration, this white stain typically disappear. It's not so much clinically visible, right? If you see from this, it is not so much visible here, right? So there is a protocol for Icon, whether it is going to work or not. Before suggesting, you can, because this is an expensive kit. Icon comes roughly around, if I'm not wrong, maybe 15,000 or 16,000. So you have to charge patient accordingly. You'll be able to do roughly 10 cases like this, but then investing 15,000 in a kit with an expiry date, you have to be particular, right? This is bleaching application for tetracycline stain, right? This is not my case. This is after night guard vital bleaching. Said this amount of discoloration has been dealt, but it took night guard vital bleaching, I think, at around 3 months. Yes, after 3 months they were able to receive this. But yes, I have put this slide to show that what is possible with the bleaching. In this situation, the patient practically did, according to the case published, just a composite bonding here, right? That's it. And patient was happy with this white thing, right? And because it was an institution based case study, they didn't bleach the lower to act as a control. And you can see the starking difference, that what wonders bleaching can do, right? So basically, there is a lot of scope of bleaching, right? And bleaching can be used like with aligners also. Like a lot of patients in which, especially the adult patient, if you are doing aligner, during the last 2-3 trays, you can ask the patient to put bleaching in those trays, 6%, 20%, and ask them to wear for 2 week, 4 week, and it will result in the whitening of the teeth, right? Pre-prosthetic procedure. I have time, Dr. Sudhir? Yeah, okay. So
Yes,
pre-prosthetic
ma'am. You
procedure.
can go ahead. You take
Okay.
till 4:30 or 5 p.m. also. I have to
No,
check
no.
what I have set the time. I think it is
Okay.
5 p.m.
Okay,
Everyone
okay.
is interested,
Fine,
I
fine,
think.
fine.
Hope
Okay,
so.
so in case of porcelain veneer, you can lighten the tooth structure, right? The stump shape. Supposingly, patient, like in this case, if the patient is gonna go for veneer, right? The amount of tooth structure you require to remove in this teeth versus this teeth will be significantly different. Because in this case, the technician will have to use require a lot of space because they have to put a lot of layer of opaquer of the dentine to mask this dark stump shape. Whereas in this case, you can go with the thin veneers also, right? So what are you essentially doing in that case? You are essentially saving this cervical margin, right? If you are resorting to the veneer first, sorry, bleaching first and then veneer. So this is the magic of whitening to enhance the longevity of your veneer bonding, because veneer bonding is a very basic smile designing concept we do, right? And if there is shade improvement required and patient is willing to go for bleaching, then what it does, it basically reduces the amount of tooth structure we need to reduce in order to provide the shade improvement required, right? And what is there is a value that if the stump shade is A3, technician will require 0.7 mm thickness or more. 0.7 mm thickness at incisal edge is not a problem, but 0.7 mm thickness at the cervical edge, huge problem. Why? Because then you will be bonding to dentine. Dentine bonding improvement has happened, but it is not as good as bonding to enamel. If you have bonded to enamel, then your porcelain veneer will have to be redone only in cases of recession, right? Whereas if you are bonding to dentine, although now more sophisticated, predictable dentine bonding protocols are available, are in place also, right? But still, if you can just introduce one process, don't charge it for the patient, just adjust the cost in the veneer maybe, right? Add extra 5-7 thousand in the veneer. Supposingly you are charging, you are doing upper six, right? And you are charging, let's say 15,000 basic, 15,000 for the veneer. So just add 16,000. You'll have 6,000 max to max. The investment cost for the bleaching is 3,000. You're making money there also, right? And most importantly, you are saving, you are prolonging the predictability of the veneer bonding. Because for a A1 stump shade, only 0.4 mm thickness is required. 0.3 mm thickness is all right also, right? So basically, because so you basically preserve the cervical enamel, and most of the failure of the bonding of the porcelain veneer happens at cervical, gingival level. It doesn't fracture on incisal level. Of course, it does fracture, but then it has got more to do with the designing and the preparation part. But at the cervical level, most of the failure happens because of the bonding issues. And bleaching will provide you with a chance to be able to bond with the enamel. So enamel preservation along the cervical margins. Uh, okay, this is one case in which I wanted to show you that why different thickness is required. Like this is a darker tooth and this is a lighter tooth, right? So the amount of reduction done on this lighter tooth, this lighter tooth is less, and the amount of reduction done in this darker tooth is more, right? More not because of the material strength, more because the masking effect it is required. If same amount of reduction is done, this tooth will appear darker, right? So this is the case in which this is the thin one and this is the dark one, right? So modifier has been used so that post bonding, these tooth will appear same, right? So this is one case of composite veneer. This is pre-veneer. This is patient was not happy with the shape because of course this laterals were missing and these were canines. So this was the digital mock-up done that this canine has to be transformed as lateral and these premolar have to be designed as canine, right? Only the buccal aspect of it. So this digital mock-up was done. This is, and then bleaching was done because there is a shade improvement, right? And once bleaching result has been stabilized, then the bonding has done. This is the same. The mock-up, digital mock-up has been transformed into the, so this you can do with ceramic also, this you can do with composite also, depending on the requirement, right? This is again, this is night guard vital bleaching, this is normal bleaching, there is restoration here. So this is after all the post bleaching and the restorations, right? This will require a crown later on. This is composite, and this is post repro. This shade improvement was done, and then bonding was done over here, right? Because of the incisal edge here was fractured. And this all is possible if you document your cases, right? Because what we do, we have a blind eye toward our cases, right? कि हमसे तो गलती हो ही नहीं सकती है, right? But trust me, when you start taking or documenting your cases, there are a lot of things which you miss clinically. Trust me, it's a very common procedure. Your dentistry improves a lot. Invest in good photography. Be it a mobile photography also. Don't resort to DSLR photography if you're a beginner and you have your own apprehension and reservation. Because besides patient motivation, it's a great tool for self-learning. Your dentistry will improve. Because eventually, whenever you are editing the cases, you will see the cases, right? And you'll see कि वहाँ पे composite रह गया, वहाँ पे ये नहीं निकला, वहाँ पे वो polish नहीं हुआ, right? And then because essentially our eyes can only see the things our mind knows and mind will know only not in a active if you're not using magnification you are less likely to miss a lot of intricacies of dentistry. But if you are using high quality photographs and you are blowing it up into your laptop and you are seeing it, it is very good for your self learning. The contacts you are making, the dentistry you are practicing, what are the drawbacks left out. So you go back to those images. If you are taking the pictures, you go back to those images. You see, you try to find out the mistakes. The mistakes you have perhaps you were able to find in others' cases, but not your cases. And trust me, once you will start documenting the cases, you will find the mistakes in your cases also. But then that is not to demoralize you. That is basically to motivate you. Because once you know, your mind is automatically trained to look for those mistakes subclinically also, subconsciously also, right? So you will take care of this thing. There is no excess cement. There is the margins is polished. The adaptation is right, right? These little thing results in, a brilliant dentistry and a moderate dentistry. Average dentistry and a brilliant dentistry, that's the just tiny bit of those finishing touches. And it is only possible once you document your cases. And in bleaching, it is very important because of medical legal case also, especially if you're doing both the arches. And it is good for patient motivation also. It is good for patient conversion also. जैसे अगर आपने केसेस का उनको दिखाया, आपने नहीं भी किया हुआ है, पर you know what to do. And if you show the patient that this is the possibility, this is how we can do this and that thing, and you tell that this is separate case, but yes, it will be adapted according to your, like in smile designing we do now, virtual smile designing is also there. Mock-ups can also be done on the patient's mouth. So patient motivation can be done by before after photographs. If you have your own database, the credibility is too high because you have done, and there is a confidence in your tone, in your pitching, because you have been there, you have done that. But if you are doing it for first time, polish your base, clear your theory, talk to the practitioner or the seniors who have been doing these kind of cases. Do a case discussion. Don't straight away jump to the case. You take all the records, you ask the patient, just like medical practitioner. They do advise you to get the test done. They do advise you to get, let's say ultrasound done, MRI done, CT scan done. They'll only write the symptomatic medicines then. But the final medicines will be written or the final procedure will be planned according to the investigation. Similarly, if you are a beginner and you don't know, you document the case, you take a good quality picture, you learn the basics of dental photography, you discuss this case with any mentor. And trust me, all the mentors are happy to, you know, mentor you, happy to tell you that this is the protocol, this you can do, that you can do, right? And then take baby steps, do one case, take the pictures, evaluate whether you are doing it right. You discuss it with your mentor, you discuss it with your senior, your colleagues, if they are doing the same procedure, right? You can't discuss with a novice, you have to discuss with a person who has been doing this, of course. And because they must have done the mistakes you are doing now, and they will be able to tell you that this has to be avoided. And that is how the dentistry improves. So documentation is very great tool for improving your dentistry, even if you know, right? And documentation, there are standard protocol. This is for DSLR photography. This is just a little bit of it, that use the same camera, use the same flash power, because the flash power varies. Flash position also varies, so same flash position, same magnification ratio, same exposure, and same ISO protocol, right? So these are the DSLR concept. Especially if for the bleaching cases, it is very important that you take a frontal facial photograph. This is frontal smile anterior, and this is retracted, right? So this is the camera setting for DSLR. If you want, and if you're using DSLR, I think you all are aware. If you're not, you can take a screenshot of this. And that exposure should f-stop should be 22, ISO should be 100, and shutter speed should be 1 of 200 second, or 1 by 125 seconds also work. For the crop lenses, 1:3 magnification. For the full frame, 1:2 magnification. And the point of focus should be on central incisor, right? And camera should be parallel to the tooth surface. So camera should be parallel to the tooth surface, point of focus should be on central incisor. This you can use in your mobile photography also. Maybe you are not able to alter this camera setting or control this camera setting, at least not in iPhone. In Android, you can manage this ISO. I'll talk about it in later slide. So, and this is your retracted occlusion. It basically stays the same, but the retraction, basically the retraction removes the soft tissue interference, and you are able to see molar to molar, right? So, and for dental bleaching, it has to be taken with a tab in this situation before any procedure is done, before oral prophylaxis is done. And before bleaching, you have to do a oral prophylaxis or basic polishing, right? Take a shade guide, whatever shade guide you are using Vita Classic, you are reading 3D Master, you are using linear guide. You just find the shade which matches the most to the central or the lateral, not to the canine, because canine are naturally one shade darker to the natural tooth. Place it along the tooth, take a picture in which the shade number is also visible, right? Because if you are bleaching both upper and lower, patient will not be able to notice any difference. So that's why you take a picture with a shade tab. And then after the procedure, before removing the retraction, you take a picture of post bleach with the shade tab which matches. This way, you can use that picture of the previous shade guide versus the existing shade guide post bleaching to show the patient this is the shade improvement we have been able to achieve with one session, right? And you can use multiple sessions. You can devise those sessions according to the requirement and patient's satisfaction, because this is not an objective thing. Filling is an objective thing. Implant is an objective thing. Crown is an objective thing. But the color is a highly subjective thing. Patient can be happy, cannot be happy. He or she may want, I want further whitened teeth, right? Especially this is very common in US, not so in India, but yes, US, it's very common. They want ultra white, milky white teeth, right? They have their shades of composite also in bleach shade available, right? Which are absolutely milky white, right? So yes, this is a subjective thing. You can tell the patient, this is the shade improvement. Would you like further? We can schedule it and accordingly, right? For this mobile photography, you have to go for a pro mode, which exists in Android only, not on iPhone. But iPhone, I believe there are certain applications which you can download. I don't remember that on top of my head, but yes, there are certain uh, camera maneuver setting in which you can do this in iPhone as well. So go to the pro mode, Android mein, select the ISO to be 100 or 200 also. Exposure should be -1 because for the mobile photography, the flash has to be on, and flash has typically bright intensity. अगर आप मोबाइल से फोटोग्राफी कर रहे हैं तो you might have noticed that the teeth become very white. So in which if you do the exposure -1, it will compensate to the flash intensity. Again, it depends. You have to do some hit and trial, and you have to evaluate the picture on your mobile phone with the one on your patient's existing mouth, because this is something you have to do as a hit and trial. That exposure should be 1, sorry, it has to be minus, right? So it could be -1, -1.3, 1.2, 1.5, depends on whatever is your flash setting, inherent flash setting, because I don't think flash is something you can control on a phone. And the color temperature should be 4000. For DSLR photography, it has to be 5500, right? The daylight temperature. But for the mobile photography, 4000. Why 4000? Because the flash has typical yellow light, right? So if you are using this 4000 K temperature of the setting and the exposure of -1, in my experience in the cameras I have tried on Android phone, it result into pretty close realistic. And you can always tweak this thing. You can always underexpose it to the more negative side, or if the photos are coming darker, then you can reduce the exposure to -0.5, right? 0.7, 0.3. You can reduce the color temperature. See, color temperature is nothing. Like, if the pictures are coming too blue, it is cool, right? 3000, 4000. There is this Kelvin temperature. And the photograph you are taking, if they are coming more yellow than the natural tone, then you have to reduce the color temperature. But if it is coming blue, then you have to increase the color temperature, right? So more yellow, then reduce the color temperature. More blue, increase the color temperature. This just, tweak around and you'll be able to find a good bow. And try to, because you don't have a magnification ratio or a zoom, perhaps you have a zoom, but you don't know that, because mobile have this autofocus thing, right? So try to stabilize the mobile phone from the point where you have taken your first photograph. Just ballpark it, not because you don't have almost precision, but yes, the composition of the teeth should stay same, right? And these are certain photography accessory. This is C-type retractor. This is contraster. This is your for lip retraction, upper and lower lip. This is for cheek retraction for taking your lateral views. And this is your occlusal mirrors. You can have your sectional mirror also, but for typically bleaching, cheek retractor is more than enough, right? And then smile designing with whitening. This I have already discussed, that for the veneer and the crowns. Crowns, if crowns not per se, but onlays, right? Because onlays, what is happening, that you are reducing only top half of the crown, not the lower half. And if the lower half is too dark, then you can bleach it before. If the patient wants that, shade improvement has to be done. Harmonizing the smile, because everybody loves white smile, right? White teeth is typically associated with success also, with happiness also. So that's why, uh, if the you will never find a person who's satisfied with their shape and size of the color tooth not smiling. You often find shy people because they're either having some psychological issues and some emotional issues. That's a different issue. But from the dental perspective, if the patient is unhappy because of the shape, position, color, then only they'll not smile. Otherwise, and the shade matching techniques. Shade matching techniques, as in that when should you do the shade matching, if you are going to do for your restoration, if you are going for your veneer, what is the time lapse? Typically 2 weeks. After 2 weeks, you should be able to do with your definitive procedures, right? Then there are some ethical and boundaries which you have to practice. informed consent. It is very, very important. I can't emphasize, because though it is not a major legal hassle in India, but it is required. You need to have an informed consent. You'll get a lot of samples of informed consent, as in, just like your third molar root canal implant, bleaching informed consent also exists. You can just get it print out into your letterhead, or even if not into your letterhead, you just inform the patient and you get a sign for every procedure, whatever you are doing in your clinic. It is like, you have to have informed consent, and you have to set a realistic expectation, that what is expected. Because bleaching, uh, for some reasons, has a situation where it becomes stagnant. Supposingly there is a A3 patient, right? After one bleaching it has gone to A2, second bleaching it hasn't gone to A1, right? So it's not that because your bleaching is issue. If you are doing everything right according to the protocol, then the tooth has reached its maximum whitening potential. That is something documented in the literature, that it varies to person, that what is the level of whiteness you can achieve with whitening. It's not that you can keep on whitening कि 1 साल तक ट्रे लगा रहे हो और दांत एकदम सफेद हो जाएंगे. Not necessarily, right? Because everything comes with their pros and cons, and anything prolonged use is not advisable. And then there are follow-up care protocols. Follow-up care protocol basically asks the patient to avoid taking foods with, because in Indian setup we consume a lot of turmeric and a lot of curry. So it basically stains the teeth. And after whitening for first 72 hour or 1 week, if the patient can avoid anything like tea, wine, or food with turmeric and curry powder, the whitening is going to stay for longer, right? And it does come with a what do you say, expiry period, that after a couple of years you will require to redo it, and you have to inform this patient that depending on the lifestyle he or she is having, she might require some maintenance phase, right? Like how we say with composite, if you're doing composite bonding for the anterior, we do tell patient that after every 6 months or 1 year, you just come for rough finishing and polishing, because composite tend to stain. Similarly is with the whitening. You tell the patient you'll have to come for a follow-up every 6 months or every year, right? Again, it will vary depending on the patient, right? That what kind of precaution, what kind of lifestyle they are having. Right. So patient lifestyle advice, you can advise the patient to, change the lifestyle if they want the whiter teeth. Maintenance and touch-ups, again, you can opt for either in-office bleaching after every 2 year, 3 year, because usually if done right, 2 to 3 year, it's last. Easily it lasts, right? And otherwise you can always touch for maintenance, because sometimes, see, standard is like every 6 months you have to come for oral prophylaxis. But we all have come across patient in which there is a lot of subgingival deposition happens every 3 months also, right? So we call those patients specifically. So those are those cohort of the patient. So you need to identify, and identification and patient confidence will stay if you tell this beforehand, right? Before you are proceeding with the case. If you do it beforehand, patient will not feel cheated. Patient, you have gained the patient's confidence and faith and everything, because you have informed it prior to its happening, right? If you are doing it other way around, right? Once you have promised कि bleaching कर दिया 3 साल कुछ नहीं होगा ये वो, and then the patient is coming back, let's say after 3 months, that she's not happy with the color. So then you've already informed in the informed consent. So patient is coming mentally prepared that I need some maintenance, I need some touch up, I need to refill it up, right? And when whitening is not advisable, there are certain cases in which whitening is not advisable, like if there is any existing decay, any active gum disease going on, perio issues are there, mobile teeth are there. So first you stabilize everything, right? No active decay, no active gingival disease, no active infection, and no existing dentinal hypersensitivity. If there is existing hypersensitivity, patient is liable to land into exaggerated hypersensitivity post whitening. So these are the things you need to rule out after, beforehand, right? And since this was a very short time and I have touched up in briefly most of the clinical thing, but how to do it right and what all protocols, how to implement that in your practice, we do run some courses on whitening also, in which typically there is a full day clinical training. There is a product walkthrough about various brand, what are the advantages, disadvantages. You'll get a demo, you'll get a hands-on also if patient is available. And it's a small group, typically 5 to 10 people at a time, not more than that. So in case you are willing, you can scan this QR and you can get back to me for further refinement of this thing. And in which we'll master the science of truth discoloration, what all things, because I touched briefly, right? What are the whitening systems and technique, right? You have the broad idea that these are the things, but what are the products available to you? What are the products you can get? How to use those products? What are the pitfalls to avoid? What are the protocol to be used, specifically customized, because it's a very customized recipe. It's not a standard protocol. It's not like, it's not like your composite filling that, you did your preparation, you did your etching, you did your bonding, and then you did your restoration, right? It is basically tailored according to the stain requirement, according to the patient, and how to manage the patient expectation. What is the reality of this? How to get it stable? Because the most disappointing result of whitening is within 2-3 weeks everything comes back, right? So, and there are in-depth clinical analysis of the cases which I've briefly touched upon, that how we manage those cases, what all things we have done, and how we have resulted into a stable results, right? So the takeaway message for this is you have to understand the whitening options, which we have briefly discussed. Diagnosis is very important from the moment patient walked in. Medical history is important. Dental history is important. Dental examination is important. Everything is important. There are safety and there are side effects. So what all safety measures you need to take? What all side effects can happen? How to counter those side effects? What all precautions you can take prior, maybe before setting in the whitening, right? So these are the things which has to be very patient specific. And then there is post whitening maintenance, which you can educate the patient that how to take care of certain things. Because anything you get it done, you tell the patient कि रूट कनाल के बाद ये नहीं करने का, इम्प्लांट के बाद ये नहीं करने का, वाइटनिंग के बाद हम कुछ नहीं कहते हैं कि क्या करने का है क्या नहीं करने का है, right? So there has to be a post whitening maintenance. And thank you very much for your time and patient listening. And
Yeah.
these are the further trainings
Then,
also we do.
Can
In
we
case you
take
are
the
interested.
questions because we are remaining with only 14 minutes.
Okay,
After
okay,
that,
fine.
meeting will automatically get
Disconnected.
closed.
Okay.
Yeah. So
Yeah.
can you take the questions? Should I read it
No,
for
no,
you?
no. I'll just read it. Okay.
Okay.
Okay. What is the concentration of HP doesn't require anything above? Dr. Ganesh has asked, what is the concentration of HP that doesn't require light activation? Anything above 30% doesn't require light activation. Right. Does bleaching affect composite bonding? It definitely does affect composite bonding. The bond strength are significantly lower, right? So you have to wait, because what happens that nascent oxygen is trapped, right? So nascent oxygen is trapped into that, and it takes roughly 2 weeks for it to get leached out of the thing. And that's why the bleaching, the residual bleaching effect lasts for 2 weeks. So first 2 weeks post bleaching is very important, and you shouldn't bond any composite for first 2 weeks. What would you suggest in severe enamel and teeth are dark brown in color? Again, if the enamel is brittle, then bonding is also compromised, right? Now the question is, what is the age of the patient? If the patient is of definitive age where bonding and the amount of enamel, the extent of enamel, if it is up to, let's say, 30%, 40% of the surface area which is brittle, and rest 60% of the enamel, And if the enamel in the periphery is intact, then you can go for composite bonding also, right? You can go for veneer bonding also. But if you think that enamel is so brittle that bonding cannot happen, then you should resort on full crown. For full crown, you have to evaluate the age of the patient. If the patient is of that age where definitive crowns can be given, because crowns is an extremely destructive procedure, right? You remove approximately 40% of the tooth structure, right? And if the crown fails, then you will perhaps maybe able to refabricate another crown, right? But how many times will you refabricate the crown? Eventually one point it will come, it is known as a restorative cycle, that supposingly decay has happened, then you do the filling, then you do the inlay, then you do the onlay, then you do the crown, and eventually implant, right? Because cervical decay, secondary decay, something could happen, right? So depending on the age of the patient, if the bonding is predictable, go for composite bonding. If the bonding is unpredictable and the age is okay, go for full crowns, because then those will be retentive preparation, right? Because veneer and composites are essentially non-retentive. We rely on adhesive dentistry for them to retain, right? Which one is the best kit for whitening? See, anti-wet I haven't used personally, but people who have used it, they vouch it. It's very good for fluorosis. And opalescent, Polo Plus, FMG, all of them are good. But opalescent is the gold standard, and this is what I personally use. But all of them are good. All of them are good, right? As we know, patient undergoing home bleaching and having sensitivity is extremely unlikely unless the patient is loading excessive amount of bleaching gel into the tray. So you have to ask the patient to bring the tray, bring the gel, and ask them how much are you dispensing, right? It is more likely that they are over dispensing it, and over dispensing causes the flow to the gingiva and causes the sensitivity. So it has to be rice grain size only, not more than that. You just want a film, you don't want it to be soaked in, right? Film is enough because it's a closed container, right? After bleaching, if the final result is okay, see, again, Colgate whitening toothpaste has got some abrasive, eventually the enamel will be lost. You have to educate the patient that it will not, you will be losing the enamel at a faster rate, right? So maybe offer a complimentary whitening session. What's the harm? It's a practice building technique. आपका कुछ नहीं जाएगा. I mean, if the patient is gonna speak ill about it, that will be more damaging. You can offer a one complimentary. If the shades are not resolved, go for night guard vital bleaching. It usually resolves a lot of problem. Thank you so much, sir. Oh, deep insight, nice.
All the questions are done.
All the questions are done. Thank you so
Anyone
much.
is there who wants to ask any question? Yeah,
Okay,
one more question is there, ma'am.
yes, which one is best internal bleach? See, I have used only opalescent endo, and I am not aware if any other endo bleach is available in India. Right. So I can't say because I haven't used it. Right.
Pola Office is very famous.
Pola
And
Office,
it is
I
very
haven't
cheaper
used in
also.
endo. I haven't used in
It's
endo.
good. It's good. Okay, yeah. It is also good. It is cheaper, but Opelson's has better quality than, and
No,
it will take
personally,
over
I
Opel.
feel ki
It will
Pola,
take over Pola Office anytime.
right. Pola
Results of
Office
Opelson.
initially when I was ordered, because there was some shortage of opalescent. So what was, they were technically offering, powder and liquid kind of thing. And opalescent is very easy to handle. Right. So that's why I
Okay.
never used Pola Office, I think.
Fine.
Yeah.
Okay, ma'am.
Thank you so much, lovely audience. And I think you guys are able to, get some knowledge about it.
45 were there.
Good, good, good. Thank you so
Thank you
much.
for wonderful presentation, and it was very deep insights were there and in detail presentation. I think one of the best presentations for the teeth whitening. All the aspects have been covered up in this presentation, and each and every detail uh, in detail explanation was there for each point. So thank you.
Thank you so much. Thank you so much.
I think everyone must have loved to attend till end, and it's
I
good that
believe.
I had kept it for 5 p.m. Luckily, it
Yeah,
was
luckily we
exact
crashed
exact till 5 p.m.
5
I
p.m.
had
Okay.
kept the time till 5 p.m. I keep extra time, so if anyone is interested anytime, it can be extended.
You can scan, participant can scan this WhatsApp thing. It directly connects to my WhatsApp and I will respond to
Yeah.
those WhatsApp, right? Maybe in
Yes.
some time, but be patient if you want to discuss any case that what should be the
We have
protocol.
WhatsApp group, no? We have
Yeah,
WhatsApp group also. They
yes,
can put cases,
there also, and we
questions.
can guide.
They can one-to-one discuss with you in that group, as well as they can scan that from the recording.
Right, right, right.
This will get recorded to cloud, Zoom cloud, because I'm doing with mobile today. Every time I do it with laptop. So I'll put that recording on YouTube channel. And next webinar is on next Sunday, 11th of May, by Dr. Rakhi Kapoor for topic social media marketing in dentistry to increase your patients. So you can register for that. Let's meet next Sunday. Thank you, ma'am, once again
Thank
for
you so much, Dr. Sudhir. Thank you
wonderful
so much.
presentation.
Okay.
Glad to listen from you. Thank you.
Thank you. Thank you.
We can end
Yes,
the
I
meeting.
think.
You end it from your side because you are the host today.
Okay, thank you. I'll end it.
Yeah.
Goodbye, everybody. Thank you for
Bye bye.
rendering your Sunday time.